welcome everyone, and welcome to our NHS EI Insights Prioritisation Programme, where we're looking at point of care testing at home, avoiding acute assessment. And this is our second webinar, which I'm really pleased to invite Joyty here from South Warwickshire. We are going to record the webinar, if that's okay. We're just going to do a presentation, then have a facilitated Q&A at the end. Please use the chat for any questions. We can bring those all together at the end. And then I just wanted to do a very quick plug for next week's webinar, which is the same time, very similar to this setup, where we'll be hearing from Tom Knight at Sandwell and looking at their model of care. So we will put the link in the chat if you feel that's something you want to listen to as well. And then just to finish off, once again, thank you all so much for giving up your time. We do appreciate that, you all have busy day jobs and this is an addition. So I'll hand you over to Joyty now, if that's okay. Thank you.
That's fine. So good morning, everybody. I'm Jyoti Nipani. As it says there, I'm the Foundation Group Associate Medical Director in South Warwickshire Foundation Trust. I have a couple of national roles. I am a clinical director in emergency and elective improvement team in the NHSI, and I'm also the national clinical lead for hospital transformation. We've got a few roles, and that really gives me a good idea of what's happening throughout the country, and also gives me a chance to do some improvement work in my own trust. And what I'll talk to you is the next few slides. I will talk to you about, if I can impress upon everyone today that, within a system, within a UEC system, if we concentrate and focus on frailty and get it right, we'll probably get a good patient flow. And I just want to impress upon why frailty is so important. And I'll back that with some of the stats that we have produced based on a PDSA, which we did in March this year in South Warwickshire. Now, everyone knows in the national news, this is there again, ambulance delays, handover delays everywhere. Patients are not able to get ambulances in time. And who are the people who are harmed when patients are admitted unnecessarily or have overstayed their length of, they overstay their needed stay in an acute hospital? So sort of working backwards through this chain of events, which is leading to this current crisis of ambulance, delays. It is the first patient who is really harmed is that patient in the bed who doesn't need to be on that acute bed, who wants to desperately be at home, and who is being deconditioned while staying in an acute hospital bed. Having this deconditioning, extra deconditioning, needing more packages of care when they leave the hospital, all the nosocomial infections they get when they're in the hospital, and even dying in a place where they don't want to die. So that's the first person who is actually harmed. The next person is that person in your ED who is waiting for that bed, and that if a patient in an ED is waiting for more than 12 hours, there is a significant harm for that patient. So even if they didn't come very poorly, they will become very poorly if they're being waiting in a hospital, on an ED trolley for more than 12 hours, where they really get the significant harm happening for them there, and they're not getting the right care. And the next person is that patient in the back of the ambulance who can't be offloaded into that ED because there is no actual physical space to offload them onto. And we have heard of instances where almost 2 paramedic shifts have handed over the patients on the back of an ambulance. So the patients have been getting care for 30 hours nearly on the back of an ambulance, and that is not right. And then the last patient is the patient who is at home waiting for the ambulance and they can't get the ambulance. And there are instances of patients actually dying at home with conditions which really could have been saved: myocardial infarction, stroke. These are really acute conditions who really need that ambulance desperately and who can't get it. Not only these patients, but also the staff looking after these patients. None of the staff in any of these conditions are really happy giving the care that they're giving, and that is leading to a lot of people, staff resigning. Now, looking back, looking at some stats as to why frailty is really important and what's happening to these frail older patients. This is a graph, this is a national picture, and along the x-axis, you'll see the age in, from 0 to 90 plus, and on the y-axis is the time. Don't worry about the negative and the positive. Basically what it says is below that baseline, the gray bars are showing you the patients, the length of time the patients are spending in minutes if they're not admitted. And the blue bars above the baseline is the length of time patients are in the ED if they're admitted. So what it clearly shows is even if the patient is not admitted, the older age group, older patients, more than 70, spend nearly 6 to 7 hours in an ED. If they're likely to be admitted, they spend nearly about 10 to 11 hours in an ED. Now, if your ED has got, let's say, 16 cubicles, and you've got 5 to 10 older patients, can you imagine half of your ED is already blocked with these patients who are occupying your cubicles? So there is the rest of the floor, ED has to work within a very few cubicles. So ED is perhaps not the right place to see frailty. That's the first message I want to give. If at all you want to bring your patients to the hospital, ED is perhaps not the right place, because whether they're admitted or not admitted, they spend a lot of time in ED, and that stops the flow in your ED, leading to all this ambulance backups at the, on your in front of your EDs. Looking at the admissions, older patients, and again, this is a graph showing the attendances compared to the admissions. So the number of attendances are much higher in the younger age group compared to the older ones, but the admissions are higher in the older age group. So can you imagine your ED will now run, it has to squeeze all this, so many attendances through small number of cubicles, because your older patients have blocked your EDs. So this is just to show the relationship between the attendances and admissions. Now, if you look at those admissions and now going one step into your hospital beyond your ED, those admitted patients, if you look at the length of stay, again, this shows the graph is showing you the percentage of the patients and the bed days they occupy. And it just shows that the older patients, they occupy, although the percentage is probably not that much higher, the bed days occupied by the older patients are much, much higher. And this graph is showing again on the x-axis bed days, and on the y-axis what proportion of patients population they represent in the general population. And again, over 70s, high bed numbers, and small, percentage of the population, and only 13.5% of the population contributing to 22% of the ED attendances, taking up almost 30% of the ED time and 66% of the beds in an acute trust. The reason I put this slide really is to show that if you want to do anything in frailty, the numbers coming in are small, but the bed days occupied are huge. So even if you make a difference to a handful of patients, if you have stopped a small number of admissions, you will make a big impact on the bed days. So that is the biggest lesson I want to give through this graph. So frailty services get criticized quite a lot because look, we have spent so much on our frailty services, giving this MDT and this separate space and everything for them. They've only seen a few patients. Yes, they'll only see a few number of patients, but if you do the right job and you don't actually admit a few of them, you will make a big impact on the bed days. And that is what I want to tell, show by this graph. So small numbers, big impact. In Swift, this was our frailty journey before 2016. So all our patients, and this happens in many hospitals even now, and I have this opportunity to see this because I go to so many hospitals in my national role. So patients are brought through, whether they're GP referred, whether it is 111 or the patient has called for an ambulance themselves. They always coming to the hospital is usually by an ambulance because that is the way they use for transport. They come via an ambulance, get dropped off in ED, go to an acute medical unit, and there they are picked up by our care of the elderly team. If they're lucky, they go to a frailty ward and perhaps even another long stay ward before going home. And this is normally what happens in many hospitals even now because they haven't got their frailty services working properly. In 2018, we started our frailty journey then, and then by 2018, we were trying to do this. If this is process mapping, we were trying to do value stream mapping by getting a few unnecessary steps out for the patient. So acute medical unit was the first thing we thought we don't need the patients to go there. So from ED, we were trying to bring the patients directly to the frailty ward. And that was the first thing we did. The second thing, by 2019, we thought, okay, why should the patients even be dropped off in ED? Why can't we ask our ambulances to drop the patients off directly into our frailty ward? So we started working with the paramedics who were bringing the patients to the hospital and asking them to call us before they come, so that when they're on their way, so that if we had space in the frailty ward, we would bring them directly there. So we bypassed the second step, which is dropping them off in ED. So we started working with the ambulance services very early on. From 2018, we were working with them. And then we started getting the ambulances dropped off in the frailty ward directly. So by 2020, by 2021, the COVID hit and patients didn't want to come to the hospital in the first place. So we started looking at how do we actually provide the care at home. But by doing the first few steps, by bypassing the ED and by bypassing the acute medical unit, these are the sort of results we got even very early on. By releasing your ED and making your ED work very well and releasing those cubicles, you can see that the A&E performance actually completely dramatically changes there. You're allowing your ED to function really well. The 4-hour performance, you can see how dramatically it has improved by just getting patients out of ED. And we started by getting the patients to see the right team first time. The length of stay in our older patients over the age of 75 started steadily dropping as we go along. And you can see from where we started early, it was more than 10 days. And over the years, we've now brought it down to 4 days, and we've steadily maintained it at that. So great, promising work if we carried on. So basically from 2020-21, what we wanted to do is focus on how we can actually provide that care at home rather than bringing them to the hospital. So when we looked at our in-hospital, the patients in the hospital, and this is a little table showing the age group on the left-hand side and the proportion of beds occupied by different age groups, and the proportion of patients who were not meeting the criteria to reside, it was very easy to see again that the older patients were occupying nearly 57% of our beds, and of those, 34% actually did not need to stay in the hospital. So that is what, so a third did not need to be there. And then you start looking at the notes, and we thought, oh, actually, a lot of them actually did not need that admission. They shouldn't have been even conveyed to the secondary care. And then you look at the, the paramedic notes, and most patients did not even want to get into that ambulance. They did not want to even be there. So what we really want to do is, yes, we will get flow, yes, we will get our beds released, yes, we will save money, but actually what we will be doing in getting it right is giving the patients the best experience they want. And that is the reason we should be doing this, not necessarily for the money it releases, nor for the beds it releases. The patients don't want to come to the hospital, this group especially. So the problem is why we are in the situation, why are our patients getting to our EDs? The problem is, as I said, they all come to us by an ambulance. And when they come in an ambulance, the paramedics have got 3 options when they are on site with the patient. The first one is see and treat. So they do spend nearly about an hour with older patients. That's how, and 50% of all ambulances workload is only dealing with older patients. Although they are there for all the myocardial infarction, stroke, and those big things, more than 50% of their time and the work is spent in dealing with older patients. So when they go to when they see a patient at home, the first option they've got is see and treat, which is seeing them and saying, actually, you don't need to go anywhere, you're fine. So that's see and treat. So leaving them at home. And that is this ambulance language. This paramedic language is see and treat. The second one is see and convey to ED. So they think, oh my God, this patient is actually crashing. I need to take them. And they either blue light or, use whatever alert system they have to convey those patients to the hospital. And yes, and that is exactly what the paramedics are meant to do. That's what the ambulance services are there for acutely ill patients, to rapidly transfer them to the hospital. But in this group of over 75 patients, this see and convey, genuinely see and convey, is only about 3 to 5%. The rest of them are really conveyed because the alternative pathway to ED either is non-existent or it is inefficient, or something is there that's not right with this. So this third option, see and find this alternative pathway, unreliable. And once it is unreliable, it is not used consistently, and that leads to this vicious cycle of dropping patients in ED. And once you go to the ED, which is the wrong place, admission, long hospital days, stays, deconditioning, increasing more packages of care, which we don't have, exit blocks, and again, the ambulances handover times. You can see the vicious cycle that it leads to by this, because we are not giving this third pathway, which is the alternate pathway, which is not consistent or it is reliable. And ED is seen as a safe option, but it is not safe. It is just the path of least resistance because you can drop people off there at any time because it's open 24/7, but it is often the path of the most potential harm. So what we did in South Warwickshire, we wanted to make it very easy for the paramedics. We didn't want them to do frailty scoring and give them a long list of criteria. We said any patient over the age of 75, or if they're under 75 but you think they're frail, with a South Warwickshire postcode, that's all. Basically, no big criteria. It's easy, age is easy to look at, and don't worry about whether they're frail or not. Over 75, just we accept it as frail. South Warwickshire postcode. All CAT, and with West Midlands Ambulance, we worked with them. And we said we can also have some patients who are not assessed yet by the paramedics. So at the call center itself, if you feel some patients are suitable for us, just call us directly. Or if you have a paramedic go on site and assess, that's also fine. We will give you a dedicated consultant who will take these calls from between 8 and 8. And that what we are going to guarantee you is an instant answering of the phone call. So you won't be held at the end of the phone for a long time. And the quality of the phone call will be good because it's a senior person who's taking the call and there is high quality decision making. That is all we did. So just a pictorial depiction of how we work through. If that is our South Warwickshire area, and this is a geriatrician of the day. It just comes up as God, which is great. And this is our front door frailty area, which is actually adjacent to the ED. It is not in ED. It's got a completely different entrance, and patients and ambulances can drop patients off there directly. And there it has got all the MDT. So you've got the ACPs, the therapists, the pharmacist, the nurse, and the consultant. Everyone is there. And following an assessment, there is a chance to actually admit them. Opportunity to admit them into a short stay ward if necessary. So this is the setup we have got. So if the patient is at however they're referred by GP or 911 or 999, however the calls come through, they come to the call navigation center in the Millennium Point in West Midlands. And as I said, there will be a few patients at that point where they may think actually they're suitable for us, and they may want to just give those patients to us directly without the paramedics going. But the majority of them are actually where they send, or there's a disposition of an ambulance to the sites. So the paramedics have gone on site and they've assessed the patient. And that is a great use for us, because once the paramedics are on site, They do a fantastic assessment. They do blood pressure, pulse rate, respiratory rate, ECGs, BMs, then you name it. They do such a lot, everything that is done in our ED and more even. So they already have a brilliant assessment when they are on site, and we can actually access all that on electronically. Our geriatrician can access all that. So once they have actually assessed the patient, the instructions for them is, if you don't want to convey them and you would not have conveyed them, don't call us. We don't want to know. If you have assessed them and you want to blue light them, please go ahead. Don't talk to us again. If they're really sick, you don't waste time talking to us. But if the rest of them, the ones you don't want to convey, leave them. And the blue lighted ones, exclude those two. If you want to convey, please call us before you convey. Anyone, before you put the patient in the ambulance, just call us. So that's what the instructions was. So anyone you want to convey who are not needing to be blue lighted. So these patients all would have made their way to the hospital if there was no phone call. That's one to remember. So that that's how we feel we have made a difference to this. So if this discussion did not take place, all these patients would have come to the hospital. So once there's a discussion, three things can happen. Following the discussion, the consultant can say, actually keep them at home. I've heard what you said, and I have listened. I mean, I can see what your observations are. I'm confident. Keep them at home, and we will send somebody, either an acute ACP from our acute or from the community home, and follow them up. Or we say, actually bring them to the SDEC, don't take them to the ED, and we will assess and we'll see what we need to do. But then what we then do is, once we assess, if we want to send them home, we send them home with a follow-up. So they're still medically unwell, but we now know that we can do a lot of stuff at home. Or even if they have been admitted, they still are. If we would have normally kept them for 5 to 6 days, we'll discharge them in 1 to 2 days. We know an earlier discharge. Now, this is the most important thing. All these patients who we have interrupted conveyance, or we have discharged them earlier, we have put them all on a virtual ward. And every morning, just like how the patient in a hospital bed gets a daily board round and ward round, these patients also get a daily board round by the consultant. So between 9 and 10 every morning, there's a daily board round with the ACPs who are looking after these patients at home, or it doesn't have to be ACPs, if it's a nurse, whoever is looking after them at home, they just join a Teams call, and then these board rounds take place for all the patients who are on these virtual ward rounds. They have bloods and they have monitoring, everything exactly as they would have in a hospital bed. These bloods are ferried by either hospital transport, or we have some volunteer drivers who pick up the bloods and bring them to us. So they have all the investigations exactly as they would, and once their treatment is over, they're formally discharged back to the GP. So the other beauty of this virtual ward round is that these frail older patients are not just frail, they may have heart failure, COPD, diabetes, other things, and we have an opportunity for all these specialist consultants to join this virtual ward round. So our community heart failure consultant, the respiratory consultant, the diabetes, join the Teams call on the patients who need this expertise. So if they were in a hospital bed, they would have been referred to these specialties, but at home, the consultant joins them on this Teams call, and it's a fantastic multidisciplinary, multi-speciality virtual ward round. So this is what we did basically. And as you can see, we use a system called Consultant Connect. So for West Midlands Ambulance Service, it's just one phone number that they have to call, and all these calls are audited, and we can record all the conversations which take place, which I listen to regularly. So all calls were answered within 40 seconds, and the calls are on a loop. Even if the first person misses the call, it goes to a next consultant and the next consultant. There's a loop of 4 consultants. The average duration of the call is 4 minutes 20 seconds. So we are actually not keeping the paramedics held up for a long time. We are making decisions very quickly. So this is what happened in March. We did the PDSA for March for a whole month, and the calls volumes went up. We had 250 calls. So what happened? So of all those calls, 250 calls, if you actually looked at the number of patients that the discussion took place, the calls were 250. But if you filter on, you take out all the ones which were not relevant, it was on 209 patients in that 1 month of March of over 75s. Of these 209, 21 were not frail. They were older patients, but they were not frail. They had either a stroke or something, so they needed to go into a different pathway. Of the remaining 188 patients in the month of March, 102 were not conveyed. So almost 54% were not even conveyed. So they didn't even hit our ED. So that was the high quality discussion which took place on the phone with our consultants. So what happened to the ones who were not conveyed? So the ones who were left at home, what happened to them? So 68% needed our community or our acute ACPs to go and follow them up. So these are the ones who had these virtual ward rounds and bloods or whatever. And 15% were handed back to the GP. So when we say handed back to the GP, it's not like you go away and see your GP. Our consultants actually had chats with the GP and said, look, this is all you need to do. Are you happy to now manage the patient? We have done this. The medicines need to be tweaked like this or whatever. So a discussion with the GPs are handed over formally. And we now also have a facility to bring patients back in a hot clinic. So hot clinics are becoming actually this is March data, but now hot clinics are becoming more popular. The other thing we can do with the frail older patients is not to bring them out of hours if we can help it. If they're stable, if we can bring them first thing in the morning, there are much more chances of actually managing them as same day emergency care. So the hot clinics are becoming much more popular now. So as 11% didn't need anything else, we just gave them advice, and a few of them were triaged to a telephone follow-up, just a telephone follow-up. Now, of those who actually came to the hospital, patients, that's the other thing. Even if they can come direct to the Frailty Assessment Unit, it would really help. And the others went directly to the SDECs. The other SDECs, supposing they came with abdominal pain and other, as I said, out of the 188, 21 were not frail. They could go directly to the other SDEC. And in March, somehow we were not our Frailty Assessment Unit was always full. So what it taught us was we had a gap in our frailty assessment area. We needed, so if we had enough capacity, even these, the one in the green sector could have come directly to the frailty assessment unit. So that would have left very little to go into ED, which is only 11%. And that is because they needed some X-rays or CT scans or something like that. So this is the lesson we learned, that we had, and based on that, we have expanded our frailty assessment a little bit more so that we can actually accommodate those. So again, we have shown that the ambulances, number of ambulances reaching ED in South Warwickshire are dropping because of that, especially bringing this age group. The proportion of the over 75s are dropping. And did we do well? Could we have done better? Of course, we could have done much better. Even in March when we had very, the maximum number of calls. If you look at the WOMAS data, in March, in our trust, we had a total of 1,621 conveyances, ambulance conveyances. And of those, over 75s were 720. So they're about 44% of the whole, all the ambulance arrivals. And of those 720, because we were doing the PDSA between 8 and 8 only, we should have, and 70% of the calls came between them. And 30% still come out of ours, which we knew we could not address. We should have got 450 calls. But as I said, we only got calls on 209 patients. So there's absolutely loads more room for improvement. And we could have, if we had all the calls, we could have made much more difference in the, the number of patients not being conveyed. Now, we looked also at the sort of patients who we said leave them at home, and the sort of patients we said bring them to the hospital. So these are on the top. So what symptoms did they have? So the ones on the top, I'm not expecting you to read all of it, but the ones on the top are the the main symptoms were shortness of breath, falls, UTI, and very similarly, the ones who were actually brought to the hospital, again, it was falls, shortness of breath, and the same thing. So the symptoms were not much different. And what really made the difference on whether the patient was being brought to the hospital or left managed at home is having somebody at home. If the patient had somebody at home, a family or somebody, or even if they had 3 packages of care, and we could not be assured that in between the packages of care we were confident the patient could not be safe, we then had to bring the patient to the hospital. So that was the limiting factor. But if you had somebody who could escalate if there was a problem, we had more confidence in keeping the patient at home. Sometimes if we got the call at 6 o'clock in the evening, if we get a night sitter, it would help to just leave them at home and bring them first thing in the morning. So these were the barriers, and these were the almost or the drivers to bring patients to the hospital. So we were working with the West Midlands Ambulance Service. These were the myths we bust. The paramedics think that if there's a fall and the patient is on the couch for more than, on the floor for more than 4 hours, we don't need to discuss. They are barn door conveyances. We don't need to talk to anybody. But because we forced them to make a call, they actually made the calls. And these were during the course of discussions, these things came about. So they would say, I'm just doing the call because, we are asked to call, but this patient has been on the floor for more than 4 hours. We are bringing, just letting you know. Then our consultant would say, actually, tell me a bit more about the patient. Have you picked them up? Have you put them on the couch? Did you give them a cup of tea? How do they look? Are they talking? And yeah, everything is okay, but they do need bloods. But we can't do those bloods at home. So are you okay to leave them? These are the sort of conversations we used to have. And so we bust the myth that if patient is on the floor for more than 4 hours, you have to bring them. Again, if somebody was short of breath from, and their saturations were less than 90, they felt they had to convey. But we could again talk with them following the discussion. We could say we can actually provide monitors at home. We can give IV antibiotics at home. We can keep an eye on them. Again, if they need a CT or X-ray, they thought they had to bring. Yes, but if they can be brought the following day and not late in the night, actually it could help more if they were stable enough, and we could get that confidence through sending somebody, or if the observations were all right. Again, they felt that if the Frailty unit was full, there was not much point of calling. But that is when we actually want to call them, because if the unit is full, we don't want more patients coming, and we can actually leave them at home. So these are the things we, by clinical conversations, we were able to, get those messages through. The other big thing was, if the GPs had called for an ambulance, they felt that they could not go against the GP's decision and they had to convey. And these are really the sort of patients we were able to manage at home, because at the point when the GP had given up because they had tried them with oral antibiotics, that's the point we could actually do more bloods at home, give IV antibiotics, maybe some fluids if necessary, and treat them at home. So they were the most suitable for a virtual ward. So these are the myths we busted and actually got them to think differently. I'll talk a little bit about the savings, but it's, as I said, it is not about the savings of the beds. It is patients don't want to come, and it is not the right thing for them to come. So 102 conveyances avoided in 1 month at a 50% call rate. As I said, we could have called we could have had doubled up on the calls. And if they came to the hospital, our normal conversion rate is 63%. And these patients average would have, as I said, 4.5 days. I showed you the length of stay, average length of stay. So just converting them and projecting that into a whole year, we would have probably called, we would have saved around 10 beds at this 50% call rate, but we would have probably doubled almost the 20 beds nearly if we had all the calls. This is just an approximate estimation of the beds saved. For West Midlands Ambulance, it is again a lot of money they would have saved, because this is how they apparently calculate their costings. 102 conveyances avoided, and they describe it as a low to handover time. And in Warwick, that means from the time they actually put a patient in an ambulance to handing it over in ED. And in Warwick, it is around 90 minutes because of the distances that we have. And an average ambulance unit cost, I believe, is £500. So just imagine, I mean, I don't, 402 conveyances just for that 1 month, 76.5K, and for a whole year, it would be much more. But it is not again about the money. That's all, theory. It is about the time that we actually give back to the paramedics to go back and pick those patients who are at home, who desperately need those ambulances because they're having myocardial infarctions or stroke. So it's really not about the money, it is about the time back and the patients who don't want to come to the hospital. We use in our trust, we use the Warwickshire Fire Rescue Service to actually take patients back home, because again, patients wanting to go home back from the south, from same-day emergency care, if you again ask the ambulances, you're again putting a load on the ambulance service to take them back home. So we use the Warwickshire Fire Rescue Service, very, very effective. They not only take the patients back home, but they actually do safety checks. They call the patients back 5 times, on 5 different occasions. They fit smoke alarms in the houses if necessary. They assess for trips and falls, and they do lots of other work as well. They look at, as I said, food in the fridge. There's lots of other things. So they're really a very useful service, which we have tapped into, which provides that ongoing care once they get home. So the key messages really are: avoid a conveyance as if possible and manage them on a virtual ward. Again, if they have to be conveyed, please avoid letting them go to an ED and get them straight to a frailty unit if possible. And again, if they are conveyed to ED, again, you avoid ED using ED resource. But even within ED, if they are seen by the right team directly without using the ED resource, it still saves some time for the patients. So I'll actually stop there.
Well, thank you, Joyce. And you didn't even break for a drink there. So have a quick drink. So do you want to stop sharing your screen and we can see everybody's lovely faces, hopefully?
Thank you.
That was lovely. Thank you so much. We've got quite a few questions in the chat, and I'm going to hand over to our human factors and ergonomist, Fran Ives, who works here at the West Midlands AHSN. Some of you have met her, but to others, she's an asset to us, and she's going to facilitate hopefully a bit of Q&A. Joyce's had a drink now, Fran. We can jump in.
Brilliant. Thank you so much for that. I've been looking through the chat, so I'm going to pull some questions from the chat. There will probably be more come in as we go along. So don't worry, Josie, about looking at the chat. I'll pull them out for you. So a question from one of our attendees. They're interested to hear if there was any pushback from colleagues and ambulance staff about not having to do a frailty score.
Oh, they love it if you ask them not to do a frailty score. That is the point. If you give a list of criteria and you ask them to do more work, actually making a referral is difficult. If they have to think of so many things, that is why we deliberately made it easy for them, because age is very easy. And we were more than happy to take calls. So actually, we should have got the pushback from our consultants, because they would get so many more calls. But our consultants were happy to take many calls. They didn't. If it wasn't frailty, they would direct them to the right place. So they were very happy for the ambulance service not to worry about whether they're frail or not. Over 75, just call. So that is why actually we made it easy, not a pushback for them. The pushback would have come from the consultants.
Great, thank you. Did you need any additional consultant PA sessions to man the 12-hour phone?
Okay, so basically, we already, as I said, we started our frailty journey from 2016, and the very first thing we did when we started doing our frailty, redesigning our frailty services, we realized that half the medical take was frailty. So we already, from 2018 onwards, we already had an 8-to-8 front door consultant presence in ED. Now, not in ED, sorry, in the frailty unit. So we were worried about the number of calls we would get. So for the month of March, we actually put a dedicated consultant, because we didn't know how many phone calls we would get. So there was a consultant dedicated to answer the phone. So it isn't just about having the conversation with the paramedic, because once you put the phone down, you then have to call your community services and ask them to go and see the patient. And then those community nurses who would go and see would ring the consultant back and say, look, we have done this. So there's a lot of conversations that we generate from that one call. So that is why we actually released them. But as we went along, we did this loop of 4 consultants. Now we have got 4 consultants. One of them answers the call.
Lovely, thank you. Now this may be a very long answer, but a lot of what you talked about is building trust across different professions and across the organisation and the system as a whole. Do you have any advice to the people here today on how to build that trust?
Yeah, so it's actually quite funny, because whatever we're doing here in South Warwickshire, we are trying to do it within the ICS. So, within our ICS. So what I did recently, just giving you an example, is trying to get the other 2 trusts in our ICS. I brought those consultants in one room along with our consultants. And so all 3 hospitals consultants we had in one room, and I brought all the community teams as well in the same meeting. And I asked them the question, how do you, the community teams were uniformly crying out for that advice. They really wanted somebody at the end of the phone. They said, we're happy to do as much work as you want in the community, out in the patients' houses. But if there is a doubt, we want to be able to talk to somebody and not email again and make it difficult. It's easy access is what we want. And so the question I asked was, do you want to have a networked model where one person one person is there at the end of the phone 8 to 8 for all the entire ICS, for all the community teams and the ambulance services, or do you want to do your own? They all uniformly said we want to do our own because we want to build up relationships with our own consultants. So basically the answer is it's about relationships building, knowing and understanding how things happen in your trust. So maybe that is the first point to start building up the relationships with your own teams, so that you know who you're sending, what is their level of competence, how they'll get back to you, how much you can trust. It's a trusted assessment, isn't it? So it's the same thing with the ambulance services. It is the trusted assessment. And now we know almost 50% of the paramedics who come to Warwick, we know most of them. If you meet them on the corridor, we almost say, hello, do you want to have a cup of tea? It is really about those relationships.
Lovely, thank you. Another question we've had from Graham: how do you deal with people with mental health issues and those people that are classed as serial time wasters?
Actually, it is, so we have, this is a separate PDSA that we have done, not part of this. We have identified the frequent attenders, and we have got a separate scheme for frequent attenders, and that is not just for the older patients, it is for all age groups. So we've got a dedicated a team who's looking after this frequent attenders, and it is almost providing a case manager for each one and dealing with them. It's tedious, it is difficult, and each one has their own solution for that. So we can't generalize, but the team and working through each one's issues and getting to the nub of what is it that's really bringing them. It is not the mental health. It is something else that we have to solve for that person to keep them away from the hospital, and understanding that. So it's really individual case management.
Brilliant. Firing questions at you, JC.
No, that's fine.
Stevie on the call has worked on both sides of the process, and has said that, is this going to put an increased pressure on very stretched community services?
Absolutely, no doubt about that. The thing is, to be very honest, we don't even know what is the workforce we need in the community services now as we speak, because the demand is all sitting with ambulance services. So ambulance services are dealing with things which we should normally have been dealt with by the community services. So once we actually start doing this work and we move all the work from the ambulance service to the community services, I think slowly we will understand what is the workforce we need, how long do they need to work, does it have to be a 24/7 service for the patient not to call the ambulance service in the first place, because as I said, if they call the ambulance service, all they know is either keep them at home or put them in front of ED. That's what, but whereas our community services can deal with them in the right way. Just because they're not accessible 24 hours, at the time, at the service, they will go straight to ED. So yes, we will understand exactly what the workforce may need. And I'm saying it loud and clear in all my tweets as well, that is where we need to invest in. Community services is exactly where we need to invest in if we don't want patients lining up in front of ED.
Lovely. I'm just going to jump back up to a question that Angela posed. I think her question was answered through some of your further discussion, but I just wanted to check with Angela, who originally put somebody could have an infarction without chest pain, diabetics and old people. Aren't you afraid of missing it? Now she does then go on to say, I understand now, direct to the cardio department. I just wanted to check with Angela if she's still on the call. Have you got any further questions around that, or are you happy with the answer?
No, I understand. So we're using community service mostly and using smart devices. So just to not have too much patients at the emergency departments like now is going on overall in the whole world, because it's a real problem. No, I understand. Thank you very much.
Thank you, Angela. And I think the answer is, and this is what we are getting to, because I don't know if you know, the respiratory network is trying to launch the community acquired pneumonia sequin for this winter. And they want to do very similarly, work with the ambulance services, and they've given them criteria, red, amber and green criteria. If the patient hits the red criteria, then they will be conveyed. Amber, they'll keep it in the community, and green doesn't need any follow-up. I don't know whether you're familiar with that, but that also, it will involve community services monitoring the ones in amber with the help of, the consultants in acute. Now, what will actually help is having this networked clinicians working together, the community and the acute and the GPs. If they're working together, then we can actually keep more patients in the community. So how we actually provide this access at the end of the phone for either the GP or a secondary care to the teams, the ambulance service and the community teams, so that they get instantaneous advice, stopping that person from, going to the ED. If that advice is not instantaneous, they'll make their way to ED.
Lovely. Do you have any access to older adult psychiatry if you need it for patients that are seen?
No, actually, we have concentrated on frailty. So I'm hearing of lots of other things for psychiatry, which is happening very similarly along these lines, and they may actually be more advanced than this. In fact, in the national call, I said, you're doing so much for mental health. Can we do the same thing for frailty? So I think if you look at the mental health services, they're probably a step ahead with this mental health cars. I think, have you heard of those mental health car stuff? They have direct access to the 999 services. So the 999 calls go directly to them, and they are managing them very differently. And that is what I want for the frailty services. If we can get frailty cars, but a car will not do for frailty, because you need a service which will even communicate and will drop them off in ED if necessary. So I don't want them to call an ambulance again. Sorry, more questions coming up?
Yeah, one from Graham. So how do we get the NHS to roll the service out nationally? That's a huge question.
It is, there are three things we need to, three jigsaws which need to fit for this to happen. The first one is we need to have the list of patients that we need to provide the service for. And that list of patients is sitting with the 999 now. They are getting all the calls. So somehow we need to get that access of that list ourselves and not have to send ambulances to those. So that is the first thing we are working on. How do we get access to that list of those patients? We're working with ambulance trusts. The second jigsaw, which is what you pointed out, is the workforce. Once we get all that list, the nervousness is, do we have enough community resource to deal with all of it? That is the second jigsaw. The third one is community services, and this is coming up loud and clear. They are really happy to do what they can, use all their competencies, but they do want somebody at the end of the phone instantaneously to discuss patients. If they have that backup, if they can risk share with that consultant, and if that consultant can own these patients on the virtual ward, they can do much more out in the community. And it's coming out loud and clear that yes, we will hold patients at home, but we do need somebody to risk share with us. We can do the bloods, but if the bloods come back abnormal, I need to be able to discuss with somebody. I can see that the patient is actually looking well, but I need to say, share that with somebody and then discussed on the virtual board. So that Teams meeting in the morning, the board round, is really, really important for them to air their concerns. So these are the three things. So we need consultants to be able to support that. So these are the three things: workforce, consultants or GPs or some senior clinicians supporting them, and getting the list of the patients. And all three we're trying to get messages across nationally. And there is something about call before convey. I don't know if you've heard that. So we're asking the paramedics to call before convey. They tend to convey on their way once the patient is already in the ambulance and it's too late. We want them to convey a call before they put the patient in the ambulance.
Great. Sue, I can see you've got your hand up. Would you like to come in?
Yes, it's just from a patient point of view. I wondered if patients get a choice and if you had thought about patient satisfaction.
Oh, I'm so glad you brought this up. You know what? I listen to all these calls which the paramedics make to the our consultants, because I'm so sad. And there's a lot of learning. But what I realized recently is somehow most people find our healthcare professionals think our secondary care is safe. So when they go on site and talk to the patients, they're almost trying to convince the patient to go to the hospital. And poor patients don't want to go. In fact, I'll give you an example of one of the conversations. She said, hello, this is the paramedics speaking, and my consultant says, yes, how can I help you? Doctor, this patient has just come out of the hospital for 4 weeks ago with had a pneumonia, and they are having this symptoms again, and the patient doesn't want to go to the hospital. The family doesn't want the patient to go to the hospital, but I've convinced her that if you say yes, then she'll agree. So the call was almost being made to get that yes from the consultant. And the consultant said, of course, no, they don't have to come. So, so we are almost trying to convince. It's actually patients don't want to come. They don't need to come. And those who don't need to come, even if it is their choice that they don't want to come, we should be able to look after them at home. So that is how it should be. So, yes, I think we haven't done a proper survey. I didn't get your name. We haven't done a proper survey, but I think if you actually survey patients, we will be doing it right. And as I said, loud and clear, it's not about the money, it's not about the beds, yes. It is getting it right for the patients. That is what we should be doing.
Thank you. I know my mother, I was a carer for my mother, and she hated to go to hospital.
Yeah.
But she didn't have the choice, unfortunately.
Absolutely.
But that was some time ago. Yeah. Thank you.
And even once they get there, again, we think we are doing them a favor by keeping them in the hospital. We are not. They desperately want to get back. Yeah. And we think they don't want to, we can't send them home in, late in the evening. But if you ask the patient, they're happy to go home anytime. Middle of the night, please give me my bed back. but we think we can't, we should not, and we keep them until the next day. Something happens and then another day. So this is about what happens. But no, you're very right.
Thank you.
Just looking at the chat, there seems to be an awful lot of support for that and for putting the patient first. So great question, and thanks for that answer. I think there's probably going to be a lot of people here who are really keen to understand, you know, how do they implement such a system process in their own organisation. So just reflecting back on your own experiences, you know, have you got a #1 tip for people that you think would be a really good nugget to share, that would be really helpful to them if they were at the very start of their journey?
If we can get, this is what I'm, because this is my journey nationally, even because I'm using my national hat to push this quite a lot, because anyone who listens to this think that, you know, it's good, but how do we get there? So my journey, personal journey within my ICS is, as I said, bringing all teams together. The ambulance service, community teams, and the clinicians, get them together and say, how do you want to make this happen? How do we keep patients at home? And asking the paramedics, how can you stop, you know, who do you want to have a discussion with before you, you know, when you see a patient? Asking the community teams, what is it that, what competencies they already have? How do we help them to look after, I mean, what do they need to do this at home? And asking the clinicians, how can we free you up to be at the end of the call? Are you happy to, because it's a completely different way of assessing patients. Our consultants are not used to not seeing a patient and giving advice. They are always used to seeing a patient in front, touching them, feeling them, you know, and then examining them and then giving it. This is a totally different way, trusting somebody else's assessment and saying, okay, I trust what you say, and still being responsible for the care, and they have to take that responsibility, and that is quite a challenge. They're still responsible for these patients who are on the virtual wards, who they haven't seen, and you know, perhaps, and trusting on somebody else's assessment. So that's a different way of working, and slowly the confidence is building up. With COVID, it forced us to do that, and I'm glad it did, because they are learning this new way of not having to touch and feel patients before and trusting somebody else's assessment. So I think these are the 3 things we need to bring them together. I would start working bottom up. Whatever you do from top down and say you have to do it, it will not happen unless the consultants are happy to take calls, unless the community teams want to work with the consultants, unless the paramedics will actually make the call before conveying. So we need to almost work from top down, yes, but bottom up, absolutely.
And Graham has just popped into the chat that we need to educate the general population that there is an alternative to conveyance to hospital. And I think that's a really important point. I think a lot of people will think, well, I have to go to hospital. That's the process. And so that education will be really valuable to people to know that there is an option.
Absolutely, and that is really where we can have to get to head to. I mean, I was thinking, shall we have actually national comms and tell all patients don't call 999? But then, you know, they call the alternative service. But if the alternative service is not staffed, or when they make a call, nobody picks up, or if they give advice to go to the ED, or they're not available 24/7. We are not doing them a favor. So I think we have to slowly work. This is why I said we don't know what is the capacity we need in the community services. We don't know how long they have to be available for. So we'll slowly have to build up the community services while we give this national comms that these are the alternative services, call them directly.
And hopefully, Jyoti, with the evaluation being done by the ARC for the Insights programme, that could help the picture nationally to say, actually, this is what you need, this is how it runs. So that could hopefully help, Graham, that we will be able to sort of roll that out with evidence and implementation guides and ideas, instead of what you've just talked about, Jyoti, putting it out there and actually with a bit of risk.
Yeah, because if you launch something and if it doesn't work well, people will never use it again and they'll never trust us again.
Yes, exactly.
Yeah, that is why I'm afraid of telling everyone call. What we are doing though now, any frail older patients we manage in South Warwickshire, when they at discharge, we tell them don't call 999 again, call us directly. So that is the slow way of educating the patients to call us directly, and we are building up our resources, because at the moment what's happening is the ambulance service has got the maximum resource. They're seeing half the patients. It would be easy to transfer half of their workforce to the community and say, look, this is your community workforce. They're already doing half the job. Come and work for the community.
Simple.
Yeah.
Jyoti, we've talked about the patients quite a lot, and we've talked about the staff as well. What impact, in your experience, does this have on the carers? So the carers of patients at home?
Absolutely. Yeah. I mean, carers, I think there's a lot of education we can give the carers. They're just worried. It depends on whether the carers are the families themselves or actually carers from the social care. If we can educate them to look out for early signs of escalation, that will be really good. If you look at, is your question about on the effect on the carers' attitudes and mindset, or the whole care service? Because if you keep patients at home, you need less care, less social care eventually, because you need much more care if they come to the hospital and go out. Is it about?
This is a question from Chen. So can I carer burden and support to carers? He's just they've just put in the chat.
Do you want to?
Do you want to
come on
mute,
the call
Chen?
and discuss it?
Hello?
Hello?
Chen, yeah, go on.
Oh,
yeah.
yes. I'm just trying to say what is the positive impact and negative impact on carers, because now you leave patients at home. If they have family carers, particularly, I suppose that you have to, in some way, involve carers to help monitor or provide some sort of care and assistance. So is it possible to put more burden on carer, and what support you can provide for carers in order for the pathway to work to the benefits, maximum benefit to patients?
Absolutely, that's a really good question. As I said, some of the times, half the time we had to bring patients to the hospital because the carers were not happy to do that little extra bit. But if we can educate them to do a little bit more, if they're happy to be educated, and one of the problems we have with recruitment of carers is because there is no career progression for them. But if they start learning these things and there is career progression from them, and they can move from carers to something, a bit of nursing thing, then it's a good thing for them. But if they don't want to do it, that is when we are stuck, and we have to put our community resource to complement that. And that is where we may have workforce issues when we have to send somebody else to do that bit of work. So do you want to come on that?
Yes, speaking as previous carer for my mum, I think you need to, it gives you extra burden, really. But I think in the long run, as you say, with a bit of extra support or training or something like that, the signs to look out for or whatever. But I just, well, as far as caring, it's, it's quite difficult. I think for me personally, it was always a worry. But if I got a number or somebody that I could call, I think that would help, rather than having to keep dialing 999 or speak to somebody, so that if I had a number that I could call who knew my mum or what was happening, that would be useful. Thank you.
Absolutely, yeah. So that, and also it needs to be available, that number 24/7, because whenever you, so it is that access 24/7, and the timely access is what is really the probably the showstopper. Because if you're worried at home, you would probably call 999 because you care for your person you're looking after. Yeah. So it might increase the burden. That's the answer.
There's one last question I can see in the chat. Josie, do you have good social prescribing networks?
I think we have. I don't know too much about it, but one of the things that really I was asking for when we are doing this one is, as I said, even if there was a package of care 4 times a day for a patient, in between the packages, if we were not confident that the patient was, we could escalate if there was deterioration, we had to bring the patient to the hospital. If we had something which was sort of pre-purchased 24-hour live-in carers just for a short 1 or 2 days who could do that 24-hour stay, that a family could do, then we would be able to put a lot more, keep a lot more patients at home, because you only need that for a short time while that patient is recovering from that acute episode. So that was what I was asking our social care service. Could you do that? And we were about to trial it for 4 months, just having some pre-purchased 24-hour live-in carers to offer it at the time of assessment. But I know I'm digressing here. It is a social prescribing. I'm not too familiar with what else is available. I think they have what is standard. I can bring my social care colleagues and ask them what there is, but I don't know what is there in terms of social prescribing. And is that not, it's probably not valuable in the acute phase, is that right? Social prescribing?
Michelle, is there anything that you want to come in and mention here, or do you feel that's answered your question sufficiently?
No, thank you. As I said in my little brief synopsis there, I'm just about to start a same-day emergency care service at the front door, launching on Monday, for over 75s with 2 frailty syndromes, with a clinical frailty score of 6. So I'm going to be looking after people that are potentially already got a package care at home, may well have some carer burden. And it's really, the stuff you said about the paramedics is brilliant, and it's a 6-month pilot, and actually my vision is that will be something we bring in, but it's very small at the moment. Have a geriatrician, a registrar, and me and another ACP. But it is mainly really, and it's about the respect, it's about making plans so that people can stay at home, because most of them don't want to come into hospital. And I've just done a bit of networking and mapping over the last month in terms of sort of befriending services, carer fatigue, helping with, sort of polypharmacy and elements, because obviously as much as it's very hard for you to manage what's coming at you, the community have exactly the same burden and responsibility. But you've also got these poor patients at home that the last resort is to call an ambulance because they don't seem to be anywhere else for them to go. And I was just wondering what services you had, because in my brain I'm thinking, let's not reinvent the wheel here. There's somebody that's already done fantastic work, and I was just wanting to use her brain set, really.
I can ask my community teams if they do something else. I'm sure there are things which I'm not aware of which are available. Michelle, which hospital are you from?
I'm actually down on the South Coast in West Sussex.
Okay. West Sussex.
So we're a little bit behind because of COVID. We were supposed to launch this 2 years ago, but obviously COVID has so we're running live as of tomorrow, as of Monday. As I say, it's a bit daunting, but we're going to go for it. We're passionate about what we're going to do and what we're hopefully going to try and achieve. And we're working out of the critical decision unit in the emergency department and then the emergency floor, really to just turn these patients around and stop them coming into hospital and having sort of a 15-day admission that is really unnecessary, but also supporting the people that are caring for them.
Brilliant. If you need anything, I think, is it West Sussex, which is your acute trust?
I can ping my email to you in a message.
Because we are supporting Bournemouth and Cornwall and Portsmouth, so I'm wondering which part are you from?
I'm Brighton and West Sussex. So I've been to Bournemouth. I went to Bournemouth 2 weeks ago, and we are actually using the Bournemouth criteria. I'm very aware that I'm taking up everybody else's time. I do apologise, but we're using the Bournemouth criteria for our admission because, as I say, when you look on the British Geriatric Society, they are the gold standard of how to do this. So we've stolen their formula.
Brilliant. Yeah. Thank you. We have ESIST supporting Brighton, so if you want any help, by all means, yes.
Brilliant, fabulous, and good luck, Michelle, for Monday. JT, thank you so much for answering some of the brilliant questions that we've had today. We've had lots and lots of wide-ranging questions from everybody, which has been brilliant. And thank you for taking the time to answer them so thoroughly and offering your thoughts and your experience. I'm going to pass back over to Helen now to close the session.
Yeah, and just echoing what Fran's just said there, thank you everybody for giving up time. Michelle, please don't apologise and have taken our time up. That was the whole point of the session, a real community of practice to share that, you know, like you said, not reinventing the wheel. And, you know, I really encourage everyone to bring that to the next group. And then that's my little segue plug to next week's session. So same time, same place with Tom Knight from Sandwell, where he will do similar to what Joyty's just done, talk about their model, what they're doing. And again, we can sort of pick his brains, learn from that. And we're evaluating that service as well. So I'll sort of bring it to an end there and just thank everyone once again for giving up your time. We do appreciate it and hopefully see you all next week.
Thank you.
Thank you.